right, it's 12 o'clock. We'll stay on schedule. So just want to welcome everyone and thank you so much for joining us today for our live virtual event, GLP-1 medications in the context of eating disorder treatment. My name is Diane Faison Rowe, and I am the National Business Development Director at SunCloud Health. So today's event is going to be a short presentation followed by a discussion with Dr. Kim. So just a little bit about SunCloud. SunCloud Health is a nationally recognized residential and outpatient treatment center offering compassionate integrated care for individuals facing complex co-occurring disorders, including eating disorders, addiction, mood disorders, and trauma. SunCloud Health, we are known for our personalized transdiagnostic approach that treats the whole person, offering personalized care tailored to each patient's biological, emotional, cultural, and spiritual needs. So today it is my pleasure to introduce to you today Dr. Kim Dennis, who is the co-founder, chief medical officer, and CEO of SunCloud Health. Dr. Kim is an eating disorder specialist who is double board certified in psychiatry and addiction medicine. She is a nationally respected expert in treating complex co-occurring conditions. Her work is rooted in empathy, evidence-based care, and a deep commitment to healing. She has a lived eating disorder experience, a lived eating disorder recovery experience, sorry, and brings a deep understanding of the importance of informed care and patient autonomy in eating disorder treatment. So I am just honored to work for Dr. Kim. She is just a wealth of knowledge and super excited to share this very important topic that I know all of you are facing with your clients. And so today, she's going to share her insights on GLP-1 medications in the context of eating disorder treatment. So without further ado, I would ask if you could just make sure that you are on mute. And then after Dr. Kim's presentation, about 20 minutes or so, we will be having the Q&A discussion component of the event today. So without further ado, Dr. Kim, I'll hand
Thank
it over
you.
to you.
Thank you so much, Diane. It's a privilege to work alongside you, and it's a privilege to be here today with all of you. Thank you very much for coming. And I'm just going to launch right into the presentation. It's part of a longer presentation, which I shortened for the purposes of being able to engage in more discussion with you all this afternoon. So please, as Diane said, if you have questions, put them into the QA box or into the chat box. So disclosures, I'm a board member for Zero Mental Health. I carry privilege, white privilege, thin privilege. And I have, as Diane mentioned, lived recovery experience. The recovery part's really important. Lived recovery experience from anorexia, binge purge type, and alcohol use disorder, trauma, and food addiction. So, what are GLP medications? GLP is an incretin hormone. It's a naturally occurring substance in our bodies that's secreted both by a subtype of our intestinal cells and also in the central nervous system by neurons in the brainstem. I think, as a psychiatrist and as a medically trained person, I've always paid attention to the biology and the brain as the organ that is disrupted that I've spent my career helping people treat. So GLP stimulates insulin secretion after we eat. It also reduces glucagon production from the pancreas, and it leads to a delay in gastric emptying, which increases a sense of fullness and early satiety. It improves glycemic control, and it reduces centrally in the brain feelings of hunger and food cravings. It has impact on reward circuitry. And part of how we are built as human beings is that we find consuming food and consuming calories rewarding. So GLPs work, GLP-1 receptor agonist medications work in the same way that naturally occurring GLP-1 works. And it's important, again, to understand that these are medications that readily cross the blood-brain barrier and have a direct effect on brain function and neurogenesis. There are studies that have shown that it decreases central brain inflammation and other peripheral markers of inflammatory disease. So this is just a picture showing the multi-organ impact that GLP-1 receptor agonists have, obviously in the intestine and on the stomach, also on the thyroid. These medications are contraindicated for people who have a history of thyroid cancer. These medications have an impact on muscle tissue, adipose tissue, the liver, the heart, and also the brain. And when we think about the brain and areas that are activated in response to food, it's not as simple as just the reward circuitry. The reward circuitry is part of it, the nucleus accumbens and the ventral tegmental area, which are dopamine rich. But there are many other parts of the brain, including the insula, and the lateral hypothalamus that are at the amygdala that are involved in our response and what happens at the brain level when we consume food. So this is a list of FDA-approved GLP-1 medications. And although we've heard, many people didn't even know what a GLP-1 medication was until 2020. Right. But the first GLP medication was actually being created in the late 1990s, early 2000s. And that was exenatide, which is FDA approved for the management of type 2 diabetes. And as you go down this list on this slide, you have examples of newer and newer and newer GLP medications. So starting with semaglutide, which in the 2018, 2019 was being used for type 2 diabetes. Semaglutide, which is also known as Ozempic, Rybelsus, and Wegovy, same medication, same active ingredient, different dosing regimen, and different FDA-approved indication. But from semaglutide down to tirzepatide, what has happened with these medications is that pharmaceutical companies have found ways to increase the effect of these medications, both on glycemic control, which is great for type 2 diabetes, but also on the weight loss potential. And these medications are indicated now for more than just type 2 diabetes and more than chronic weight management. So, for example, liraglutide or Victoza, Ozempic is indicated both for type 2 diabetes and cardiovascular risk reduction. Semaglutide in the form of Wegovy just got the newest hot off the press indication. This was about a week ago now for something called MASH, or metabolic associated steatohepatitis, which used to be referred to as non-alcoholic fatty liver disease. Zepbound, tirzepatide in the form of Zepbound, is also indicated. It's the only GLP medication that has an indication for obstructive sleep apnea in the context of higher BMI. So Why is this relevant to people with eating disorders? Obviously, there are many implications to people with eating disorders on any medication that can decrease appetite, and any medication that can decrease weight. Um, there's a huge overlap between type 2 diabetes and binge eating disorder. So, and type 2 diabetes is one of the top 10 causes of death worldwide. There's significant increases in the last 20 years, with the highest rates in upper middle income countries. And as a psychiatrist, it's always been important to me, from the time I was in medical school, to look at the whole person. And I think far too often in medicine, in general areas of medicine, in psychiatry as a field, in the eating disorder field, we look at our specific area of expertise and we devise treatment recommendations based on our specific area of expertise. When we do those things without an appreciation for all of the other issues that a person is coming to us with, we run the risk of inadvertently making those other issues worse with the treatment interventions that I may be designing for a person's depression, or that I may be designing for a person's eating disorder, right? And conversely, I think we've all, as eating disorder therapists and clinicians, experienced our patients with medical comorbidities, like type 2 diabetes, getting treatment interventions or messaging from primary care doctors or endocrinologists that inadvertently make their eating disorder worse. The solution to that is for me to have a bigger perspective of the person, and to actually talk to those people and bridge those gaps. Because when I bridge that gap, there's a better chance that my patient is going to get a coherent and well-informed treatment message, both from an eating disorder perspective and from an endocrine perspective. So in the United States, cardiovascular disease is the leading cause of mortality and morbidity among patients with type 2 diabetes. So these are, I share this to make sure that we are also aware of the importance of, from a morbidity and mortality standpoint, attending to what's going on with one of our patients on the medical front. It's also important from a perspective of health equity. Black and Hispanic patients carry a disproportionate burden of type 2 diabetes in our country. Black patients have higher diabetes complication rates, like amputations, for example, or end-stage kidney disease. We know that diabetes-related risk for cardiovascular disease has declined. Oh, gosh. Sorry about that. Has declined among white patients since 1990, but it's actually doubled among Black patients. And in patients with type 2 diabetes, cardiovascular mortality rates are the highest for Black patients. I think it goes without saying that the eating disorder field, the vast majority of research upon which our gold standard evidence-based practices rest, has been done on predominantly cisgendered, white, and thin folks. So understanding and dismantling barriers to GLP-1 receptor agonist use among marginalized groups is also has to be a part of this conversation. In patients specifically with eating disorders, the rates of type 2 diabetes are the highest in patients with binge eating disorder, where up to 20% of people who have type 2 diabetes have binge eating disorder, and up to 30% of people with binge eating disorder have type 2 diabetes. So this is part of why I believe that anytime a primary care doctor or an endocrinologist is prescribing a GLP medication, they need to be doing eating disorder screening prior to prescribing these medications, because it changes the risk-benefit discussion, which is the hallmark of informed consent. We know that both eating disorders and type 2 diabetes are more common in persons living in larger bodies. And people with eating disorders in larger bodies and those with type 2 diabetes are also more likely to be recommended weight loss interventions, which again, if a person has an eating disorder, is going to change the risk benefit discussion and the treatment goals and the treatment priorities for that patient. We know there's a lack of routine eating disorder screening and monitoring in primary care and in endocrinology, and there remains a knowledge gap in most weight management practices, which leaves us as eating disorder clinicians to address what is often weight stigmatizing, fat phobic, and conflicting messaging. So what are the GLP risks in patients with eating disorders? Well, there are the general risks that anybody on a GLP medication would need to know about: nausea, vomiting, diarrhea, weight loss. And there are a whole host of other risks like malnourishment, gastroparesis, sarcopenia or decreased muscle mass, hypoglycemia, hair loss, ileus, which is a condition in which your intestine basically stops contracting and stops functioning and can lead to impaction, pancreatitis, renal failure, dehydration, reduction of lean body mass, thyroid cancer, and diabetic retinopathy. Sounds like something you want to take, right? We know there are unique risks for patients with eating disorders, particularly around weight loss, appetite suppression, malnourishment. There's a lot still to be learned about impact on historical eating disorder or latent eating disorder, meaning if somebody has genetic predisposition to having an eating disorder, is being on a GLP medication a potentially triggering event to the onset of the eating disorder? We don't know yet because that research hasn't been done. Impact on current eating disorder and eating disorder treatment. We have more and more data being collected, both in the peer-reviewed literature and anecdotally as eating disorder clinicians. There is risk of misuse. We see patients every day at SunCloud who have misused GLP medications. Some of those who have FDA indicated uses for these medications and are getting them from legitimate sources like primary care doctors. Others of whom do not have an FDA indication and are getting them from illegitimate sources like online doctors and compounding pharmacies. There's a lot still to be learned about the impact of long-term use and starting and stopping these medications. There still isn't any sort of established consensus guideline around what the off-ramp looks like. And many people who take these medications are taking them with the intention of being on them for life, much like somebody might be on a hypertension medication for the long haul. And then finally, the impact on health inequities, particularly for racially minoritized people, and the impact on weight stigma and fat phobia, both of which we know also affects brain biology. So what are the benefits of these medications? Well, there's actually quite a bit of data, randomized studies, good studies demonstrating efficacy in type 2 diabetes. There are well-documented weight loss effects of these medication while a person is taking them. Weight neutral benefits, I think, are what I attend to when I'm thinking about whether or not a patient with an eating disorder should be on this medication, or it should be something we taper or discontinue. So potential weight neutral benefits would be improved glucose control, lower hemoglobin A1C, decreased risk of myocardial infarction or stroke in those with cardiovascular disease, decreased risk of cardiovascular mortality, benefits to obstructive sleep apnea, and liver disease. And then there's preliminary data showing benefit for inflammation, neurodegenerative diseases, kidney disease, and alcohol use disorder. When we think about weight loss, is this a risk or is this a benefit, or for whom? And who gets to say? I think as a field, the predominant voice as eating disorder clinicians is any weight loss is pathological as a sort of standing baseline, right? And there's a whole literature beyond the eating disorder field looking at patients who are in, for example, behavioral weight loss programs who have eating disorders and the impact of those programs on eating disorders and eating disorder pathology. And I would say the results are mixed. Is there a potential use for these medications in binge eating disorder or bulimia nervosa? There's very, very little data, some of which I will show you all. And that too, I would say, is mixed. So randomized controlled human research, again, shows medical benefits of these medications along the lines of cardiovascular disease, mortality, and glycemic control. There are very, very, very few studies in adolescents. There's a study published late last year looking at GLP medications in adolescents that showed decreased risk for suicidal ideation and improved quality of life. And this was a study that actually looked at 3 years worth of data. But there's very, very little that we know about using these medications in adolescents, despite the fact that adolescents are currently and actively being prescribed these medications. The evidence base in humans is also pretty lacking when we think about using these medications in patients with eating disorders. Preclinical studies demonstrate decreased binge eating and decreased self-administration of alcohol and drugs in rodents. So there's a lot of interest and a lot of active clinical trials right now looking at using these medications in psychiatry, in addiction medicine, and to a lesser extent in eating disorders. The initial studies on semaglutide were based on large sample sizes, multinational, and they show, again, changes in waist circumference, changes in systolic blood pressure, changes in hemoglobin A1C, changes in diastolic blood pressure. These are all non-BMI based markers of indicators of health, right? And then, of course, the thing that we hear about all day, every day is the weight loss. This is an important slide when we are talking about these medications, particularly in patients with eating disorders who have diabetes. So on the initial slide that listed the types of GLP medications, as you got further down on that list to the newer and newer medications, you'll see more and more weight loss. So this is tirzepatide or Zepbound, Mounjaro. And what you see is based on when you increase the dose, you increase the weight loss potential. And along those lines, increase the appetite suppression. Ozempic or semaglutide has less in the way of appetite suppression and weight loss, but still substantially more than oral semaglutide. That's an important distinction versus injectable semaglutide. Liraglutide, an older GLP medication, and dulaglutide, another older medication. So if I'm working with a patient who has an eating disorder, or who is in recovery from an eating disorder, and they have an elevated hemoglobin A1C and want to be on a GLP-1 medication. When I think about, okay, what are the risks from an eating disorder perspective? I'm inclined to give them the information that, there are older medications in this class that can help with your diabetes, and maybe less likely to interfere with your eating disorder recovery or maintenance of your eating disorder recovery, because they're not going to completely shut off your appetite in the way that a newer medication like Mounjaro might. So here are the studies of GLPs on binge eating disorder and bulimia. Really just a handful of studies so far, and a couple of systematic reviews. So there was a study using dulaglutide, one of the older GLP medications in patients with type 2 diabetes and binge eating disorder. And it showed that dulaglutide significantly reduced binge eating behavior as measured by the BES, weight, BMI, fat mass, and hemoglobin A1C. There was a study using liraglutide, 17 weeks. Again, not a very long amount of time, not a very long amount of follow-up, which is one of the criticisms of the few studies that we do have. Objective binge episodes dropped more in the active arm with the GLP med than placebo. And 44% of folks who were taking liraglutide achieved remission of binge eating disorder, and 36% did with placebo. Then there was a semaglutide study looking at the binge eating scale and comparing results of semaglutide versus lisdexamfetamine or Vyvanse or topiramate, both alone and in combination. And it showed that reductions in binge eating scale scores were greatest for the semaglutide group. And again, if we look at the systematic reviews and meta-analyses, there was one published that included 5 different studies, 182 participants. Again, small numbers, showed that the GLP meds significantly reduced BMI, we know that, waist circumference, and binge eating scales by 8.1 points. And there have been fewer studies looking at overall impact on psychiatric health and then bulimia as well. And again, what we see is reductions in binge behavior. But again, these are all small studies. None of them have longer term follow-up, which is problematic, obviously, because we know that after a period of weight suppression, after a period of reduced calorie intake, that it can be 3 months, it can be 6 months before we start to see reemergence of some classic eating disorder behaviors. So we're left with the questions. Are GLP medications compatible with eating 3 meals and 2 to 3 snacks a day consistently? Are GLP medications compatible with renourishment or intuitive eating? There are certainly patients who say, I can eat intuitively now because on this medication, I feel like I eat what I want when I want to and can stop and can pay attention to when I'm full. And there are other patients who are on these medications who completely lose any hunger cues at all, ever, which is not compatible with eating disorder recovery. Are GLPs compatible with weight neutrality? I think it depends on the person and it depends on the medication. Mounjaro, probably not. There's going to be weight loss in the vast majority of people who take Mounjaro. Liraglutide, potentially. Are GLPs compatible with improving in a sustainable way eating disorder cognitions and body image? We don't know. Quality of life. For some people, yes. For other people, we don't know. So I think there's a lot more questions than answers at this point. The answers to the above questions are likely to be different from one person to the next, even with the same eating disorder diagnosis. And one of the areas of research that would be beneficial is to begin to establish risk profiles that differ by eating disorder phenotype and medical and psychiatric comorbidity. And then, of course, does patient preference matter? And I think as a whole in the eating disorder field, certainly at higher levels of care where I practice, much of the time, the way that eating disorder care is executed tends to be quite paternalistic and quite authoritarian. I believe that patient preference matters a lot and should be the driver of our treatment interventions. Obviously, with psychoeducation, with clinician expertise in pointing out to a person what seems like it could be eating disorder pathology or eating disorder driven versus a person's authentic voice. But I do believe that paternalistic medicine, particularly in the eating disorder field, does more harm than good for many of our patients. So what are some practical steps for patient care? Always, always, always strive for patient-centered, individualized, flexible, multi-morbidity aware, and culturally attuned care plans. So if, for example, a patient who has limited access to good health care, who has a very elevated hemoglobin A1C, who has multiple family members who've died of kidney disease, is wanting to be on a GLP medication to increase their longevity and increase the chances of living free from dialysis or limb amputation, wants to be on a GLP medication, and they have an eating disorder that they are in remission from or actively in treatment from, but being closely monitored. If that person wants to try a GLP medication after a thorough risk and benefit discussion with their primary care doctor, with me as their eating disorder doctor, that's somebody that we're going to involve the family, we're going to honor their voice, and we're going to do the experiment and plan ahead for how are we going to know if this isn't working. Like, let's talk about some of the specific markers we will see and what we're going to do if we see these things. So I think there's a huge role for respecting patient choice and close monitoring. So ask regularly about medication changes. All of my patients know that I have spent 20 years treating eating disorders, right? And they know that that's information I would want to know if they happen to start a GLP medication. And if I don't proactively ask, that's exactly the type of information that they wouldn't proactively share. So always ask whether you're a therapist, whether you're a doctor, whether the patient knows that you're an eating disorder therapist or not. If a patient is on a GLP medication, do they have an FDA-approved indication for use of the medication? And what are their goals? If they do not have an FDA-approved use for the medication and they have an eating disorder, that's probably not a patient that, that the risk-benefit analysis is going to shake out favorably for on the benefit side. Educate, provide informed consent, commensurate with your scope of practice on side effects, absorption of other medications, lack of data, impact on metabolism, impact on eating disorder, weight stigma, lifelong treatment. As I said earlier, these are medications that are being prescribed as maintenance medications to maintain the effect that they have when you're on them. Ask for an ROI and call the primary care doctor or endocrinologist always. I would say even if your patient is not on a GLP medication, it behooves us as an eating disorder field to be constantly talking to our colleagues in primary care because that's going to help our patients. They see way more of our patients than we will ever see. Collaborate and communicate with the patient and family, and initiate closer monitoring and more frequent follow-up. In medical settings, these medications are prescribed, and there's a titration schedule that's given to the patient, and the doctor will see the patient back in 3 months. That is way too long for any of our patients to not be seeing somebody. So the patients that I have who are on these medications, I see weekly, whether they're outpatients or whether they're in our residential or PHP IOP programs. I just want to say one thing about trauma-informed care, and then we can go into the questions. Safety, collaboration, and transparency really means to me that I need to drop my agenda, or at the very least, when I have an agenda, I need to be aware of it, and I need to state it explicitly and transparently to the patient. Focus on empowerment and resilience, and voice and choice. The goal is really to increase the patient's experience of choice, bodily autonomy, and recognize that every person's experience is unique and requires an individualized approach. Again, the evidence base for eating disorder treatment does not include many, 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 many people. And I need to keep that in mind when I'm giving evidence-based treatment recommendations to my patients. Build peer support, community connection, and inclusiveness. Remain culturally attuned and gender inclusive in your care system. And carry humility. The more you know, the more you realize you don't know, and the more open you become to lifelong learning. Part of this for me, and for any of you who are practitioners who do have lived recovery experience, is to be able to recognize that what worked for me is not necessarily what's going to work for any of the other people out there. So I'm going to wrap it up there. I don't know if you want me to stop sharing my screen, Diane.
I'll go ahead, and I have a slide just with my contact information that I'll go ahead and share. So let me do that real quick. But thank you so much, Dr. Kim. That was such a wealth of information. And so we'll go into the Q&A portion now. And so if you do have a question, you can go ahead and submit it now in the chat box. I know a couple of you put in the Q&A, so I have those jotted down. Or if you prefer to ask Dr. Kim live, raise your hand and I'll go ahead and unmute you if you want to say your question live. So the first question, we'll go ahead and start now with the questions that were submitted previously. Can GLP-1s cause other meds like anxiety or ADHD meds to be less effective? I know those are different categories of meds, but I have clients that have expressed they feel it is causing them to feel like this.
Yeah, that's real. So because these medications delay gastric emptying and absorption, particularly for very quick acting meds, like a lot of the anxiety medications, things like Ativan, Xanax, those medications that people might be accustomed to taking and feeling right away, they will feel it eventually, but in a very different way. Because instead of those medications being absorbed and getting up to a peak, in 15, 20 minutes, those medications are now absorbed way more slowly over a longer period of time, and very much more gradually getting up to their peak amount in the blood. Same for quick-acting ADHD medications. So that experience that your patients describe is likely related to the GLP medication.
Thanks. Okay, next question. There aren't guidelines for dosing medications, specifically psychiatric, for patients on GLP-1, but we know that pharmacokinetics are altered. Do you have any advice?
Well, other than letting your patients know that if there are quick acting medications that you are giving them, that it's going to be a different experience for them. Um, because of the decreased absorption time, or that I guess it's increased time it's going to take for them to be absorbed. Um, most of the medications that we use in psychiatry are longer acting medications, and patients don't really notice. For example, when somebody takes Zoloft in the morning, they don't notice that they've taken their Zoloft. Right. So many of the medications that we use in psychiatry, patients won't experience a difference um, in if they've added a GLP medication, but for sure for the shorter acting medications, patients are likely to have a different response to those. So I would probably just give people really appreciate having a heads up. And I think that helps to build the therapeutic relationship too. Like, oh, by the way, you may be experiencing this. Um, and also people appreciate when they tell us something that we, you know, take their word for it. People like to be believed. I know as an eating disorder professional, a lot of times my work is like helping people understand why what they're saying is not true. Like, no, eating a cookie isn't going to, you know, cause you to gain X amount of weight or, cause you to have a heart attack, for example. But there are a lot of things that patients share with us that actually are true and are based on their own experience of their bodies, and validation in those instances goes a long way.
So I know you somewhat alluded to this question, answer to this question, but should prescribers of GLP-1 screen for eating disorders? And if so, how should this knowledge impact if how they prescribe these medications?
I want to scream this from the rooftops of like every medical setting that is out there. But yes, I believe anybody being prescribed a GLP should be screened for an eating disorder. I'm part of an international work group working on consensus guidelines around screening for eating disorders and use of GLP medication in patients who do have eating disorders. And one of the things we discussed as a group is this very question. Should primary care doctors and endocrinologists be screening? And if so, what screen? And then if they screen positive, what to do? So if somebody does screen positive, ideally, in the best case scenario, they're referred to an eating disorder professional who could collaborate with that prescriber. And I think we all know that in many places of our country, access to eating disorder care is just not there. So there's actually an article that Bartle and Susan McElroy wrote that has a really good guide for clinicians to use when talking to patients with eating disorders about GLP medications.
Okay, next question. I have heard about the potential benefits in terms of ED recovery of GLP-1s for decreasing food noise, particularly in the context of binge eating. However, what are your thoughts on using GLP-1s for people who are normal weight or people who are underweight, even if they struggle with binge eating?
Um, Yes. So there's a little bit of data on use of GLP medications in bulimia. Um, and at least some of the participants in those studies were quote unquote normal weight, whatever that means. But I think there are real risks in anybody being on these medications who has an eating disorder, because a lot of what drives eating disorder pathology is restrictive dietary restraint Mental cognition's always about wanting to restrict, wanting to restrain eating, and malnourishment. So if somebody's malnourished already, a GLP medication is going to make that worse. So regardless of what body size a patient is coming to me living in, um, if they are malnourished, whether they're at a higher BMI or a lower BMI, a GLP medication is probably not going to be ultimately helpful for them, at least until they can get to a place where they can adequately nourish themselves. Oh, you're muted.
Yeah. Oh, and then you were asked to repeat that paper study.
Yeah.
I will, if you want to send that to me too, and I'll include that in the follow-up email for everyone as
Yeah.
well. Thank you. Relatedly, from a conceptual standpoint, I often see binge eating as the result of restriction and deprivation. And the solution is to normalize eating, allow all foods to be legal, listen to your body, etc. This is a long one. Okay. But if we instead treat binge eating with a GLP-1, which actually might even facilitate restriction due to decreased appetite, does this mean we're not addressing a potential underlying root cause, restriction of the eating disorder? And might we inadvertently maintain the eating disorder and impede recovery by using GLP-1s?
Yes. So along the lines of what I was just saying, actually, if, and I think, again, so much of our field is focused on dietary restraint as the universal and pervasive and only, behavioral cause of eating disorders. And that ends up doing a disservice to people, um, a subgroup of people with out of control eating predominantly or binge eating pathology, in the absence of dietary restraint, in the absence of restriction, caloric restriction. So for folks who are not malnourished, undernourished, regardless of body size, a GLP-1 medication is going to have a more favorable risk benefit profile than anybody who is coming into the situation malnourished or in a state of calorie deficit from dietary restraint. And we don't have good ways to, we have the EDEQ with the dietary restraint subscale. There are some other measures that look specifically at dietary restraint, but we don't have great ways to measure, objectively measure dietary restriction, right? So I think there's a lot still to be learned about that. But if somebody's malnourished and I need to focus on renourishment and normalization of eating, that's not the time to start a GLP medication. And even for people who, are eating consistently, who get on a GLP medication and then aren't able to sustain adequate nourishment. Again, there's not great guidelines on this, but what I use with a lot of my patients is, whatever daily caloric intake, that they had been at. So, anybody who's not able to eat like at least 2,000 calories, 1,800 calories, a person's caloric intake depends on a lot of different things. But very few people have lower needs than that in eating disorder recovery. So if somebody's not able to maintain that as like a minimum and they're on a GLP medication, we have a discussion about changing either to a lower dose or a different medication that has less in the way of interference with appetite suppression.
Great. Some of these questions, I know they've been somewhat addressed by you already, so I'm going to go ahead with this one that was submitted in the Q&A today. Are there any studies about the intersection of PCOS, ED, and the use of GLP-1s?
Not to my knowledge, but I know there are articles in the literature specifically about GLPs and PCOS. They're not clinical trials, um, but there is a little bit in the research looking at the impact on PCOS of GLP medications. But that's a great question.
Um,
I
and
do want to just say, along the lines of screening tools, I see in the webinar chat somebody, Jessica Huber, asked effective screening tools that prescribers can use in the primary care setting. The SCOFF is like very easy. Um, there's um, there's also NIDA, I know, has an eating disorder screening tool on its website that you can just give the patient in your office to sit out in the waiting room and fill out, and it gives the person the result as soon as they finish. They can opt to share it with you as their doctor. If they do it in the office, they can just show it to you. The EDEQ is pretty easy to use. It's a 28 question questionnaire with pretty standard cutoffs for people being in the clinical range. And there's a primary care specific eating disorder screener that I could probably send for you to send out, Diane.
great. Yeah. Anything that you've shared, I'll gather that and I'll send that along with the recording of today's event. So you'll get a nice little GLP-1 gift basket, I guess. Um, are GLP-1s used by teens? That's a question
Are
that's answered, and yeah, you said
and sometimes inappropriately. Um, we've had adolescents come to treatment who are not living in larger bodies, um, and who do not have FDA approved indications for GLP medications, whose, parents' friend who happens to be a doctor is prescribing it for them. So, yes, sometimes for FDA approved indications and many times not.
okay. And so, are the side effects similar in the oral form of semaglutide? Could oral semaglutide be a good option for someone who is getting close to prediabetes range of A1C, but is struggling with their relationship with food and body neutrality?
Yes. So oftentimes my recommendation is to use oral instead of injectable when somebody wants to try one of these medications because there's less weight loss, and there's less in the way of appetite suppression, but there's still the benefit for glycemic control. And I think so much of medicine is about, you know, adjusting doses and adjusting medication types to fit the person and their response to the medication.
Um, I'd love to hear if you have any recommendations for trainers and fitness coaches to adjust, modify programming for our clients that are on GLP-1 meds, or any language you think is the most helpful for our clients.
Um, I mean, I feel like that's a whole nother like presentation, honestly. Like what language do we use in the fitness world to support people in, joyful movement and understanding why they're moving their bodies or how they're moving their bodies. I think if somebody, again, I think about calorie deficit. If somebody's in a place of calorie deficit and they're not adequately nourishing themselves, adding calorie expenditure in the form of fitness or exercise or even joyful movement comes with a lot of medical risks. So gentle yoga, stretching yoga, definitely not like uh, what I like to refer to as like yoga on steroids, or like, no offense to anybody that does like hot yoga or whatever, but high intensity energy expenditure is contraindicated in somebody who is in a state of severe calorie deficit. That
Okay.
is my biased view as an eating disorder professional. But you will find plenty of, I think part of the issue with this is these medications are being prescribed along with lifestyle modifications, including like getting, some amount of cardiovascular exercise, movement, nutritional changes, and in the absence of, you know, also being able to give the patient, I want you to continue to eat at least X amount of calories a day. And if you're not able to do that, call me right away. Um, like that discussion needs to happen so patients know, because a lot of times patients are like, oh, well, I'm on Ozempic, so of course I don't eat breakfast and lunch. Um, and they have no idea that that's um, not healthy for them, and that's a sign that this medication that they're on, either in its dose or the type of medication, is not um, a good medication for them.
I know. Okay. Unmute. If a patient is on GLP for weight loss, is there a marker that you use, like BMI, to begin to wean them from the medication, or do they have to be on it forever?
So I'm not a primary care doctor. I'm a psychiatrist. These medications are certainly used. They're being used more and more and more in psychiatry, um, particularly in people with bipolar disorder or schizophrenia who are on atypical antipsychotics that we know can worsen people's health by increasing hemoglobin A1C, increasing cholesterol levels, right? But there's not a BMI, there aren't consensus guidelines around how to, when to, if to take people off of these medications. Right. So most conversations that are happening when people get on these medications are you prepared to take this, for the long haul, um, for the rest of your life? Because it's a medication that works when you take it. And I've had patients who've gotten off of these medications. I've had patients who weren't able to get the medication because of shortages, or this week insurance isn't covering it, but last month they did. And it's a dramatic difference in their biology, and it's a dramatic difference in their appetite. It's a dramatic difference in what they're eating, how they're experiencing food. So I don't think we have much at the present moment to say this would be an indication to get off of this medication, and this is how to go about doing it in order to preserve the hemoglobin A1C benefits and the cardiovascular protection. You're still muted.
I'll just leave myself on mute and just be quiet. Okay. Questions are continuing to come in. So this is from Heidi. I've come across GLP-1 RAs helping treat MCAS to decrease gut inflammation. However, MCAS co-occurs with many people on the hypermobility spectrum with an already delayed gastric emptying from their GI's natural ability to stretch. Wouldn't using of a GLP-1 RA be counterintuitive in this population?
Yeah, so MCAS is, I'm assuming you're talking about mast cell activation syndrome. And anybody who has issues with delayed gastric emptying, including people who've had or who do have atypical anorexia, or even histories of anorexia nervosa, and have ongoing delayed gastric emptying, or any other condition that's associated with delayed gastric emptying, that's going to get worse on certainly on the newer GLP medications, which have more pronounced impact on the GI tract.
Okay, I'm not on mute. Okay. Sydney has this question. Hi, Sydney. So you mentioned GLP-1 and
Sydney.
You mentioned GLP-1 and alcohol use. Have using patients benefit from the GLP-1 and decreasing their use, but it has impacted or kicked off disordered eating?
So for sure, I've seen, not specifically with alcohol use disorder, have I seen people impacted it, having it be beneficial for one thing, but worsening something else. But for sure, I've had patients who are on these medications who can't tolerate being on them. I think one of the things the research is very clear about is that even though these are billed as for life medications, I think after a year, right around 50% of people are no longer taking the medication because they stopped it and they can't tolerate it and they don't want it. So I think there's a lot to be learned about eating disorder risk and the development of eating disorders in people who never had them once they've started on these medications. But we don't know yet. I haven't seen it necessarily with people who are taking it off label for alcohol use disorder.
Okay. And I know we're at the top of the hour, so I just wanted to acknowledge anyone's time if they need to leave. Dr. Kim, do you have a few more? We have a few more questions. Do you have
Yeah.
a little bit more time? Okay, so
Yep. For
apologize
sure.
if you need to leave, totally understand. But again, if you registered or have your email, we'll send you the recording as well as some of the links with the screeners and the publication that Dr. Kim mentioned. Um, so here's a question. What is the average calorie intake for those taking these meds?
It it varies widely. Some people are able to consume 2,500 calories a day. Other people get on these medications and literally are only consuming like 800 calories a day. So it really depends on the person, the medication, the dose, which is precisely why close monitoring and asking these questions are really, really important.
Okay.
I see a question that I think is a really excellent one. What it's from Jessica Cortez. What
Oh,
is the
I was just going to
presentation?
read that. Yeah.
Okay. What is the presentation of an ideal patient that you may bring up the use of a GLP-1 to help treat their ED? Is this something that ED psychiatrists are initiating as treatment intervention for the treatment of BED or BN without the FDA indication? I think is the question. So I would say most eating disorder psychiatrists are not like initiating that conversation. What we do have a whole lot more of are patients coming into treatment or staying in treatment who are on these medications. Um, and sometimes that is an okay thing and actually a useful thing for them, and oftentimes it's not. Um, but if I had to think about an ideal patient, so there's a patient that I treated that I considered talking to about using an older GLP medication. I would say the BMI was probably around like 28, maybe. Um, did not have diabetes, did not have cholesterol, but had like intractable and severe, extreme, if we're using course specifiers, bulimia nervosa with massive, massive binges to the point where she would have to go to the ER um, because she had consumed so much food and her stomach was so distended. Um, and she had all sorts of medical complications because of that. Um, her 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 parents were well-educated academics at an Ivy League institution, and we're looking at all sorts of different options because they were just at their they'd tried everything. She had CBTE, like all of the standard eating disorder treatments she had tried. Um, and So she was somebody that I had the thought and talked to a colleague about it, but never ended up having the conversation just because this was probably a couple years ago now. Um, would I do that differently now? I'm not sure. But if I think about an ideal patient, it would be somebody who has predominantly binge eating pathology, um, is not malnourished, um, is in remission or recovery from binge eating disorder or bulimia and has an FDA indication. If it's somebody with active binge eating disorder and they have an FDA indication for the medication, potentially after a thorough risk-benefit discussion, certainly if their medical comorbidities from untreated or undertreated cardiovascular disease or diabetes was putting them at risk of dying or a lot of morbidity. So that would be the ideal type type of patient. And I would watch them very, very closely, not see you back in a month or 3 months or 6 months. So,
Yeah, well, it looks like just making sure. Does anyone have any questions? Let me see. Is anyone raising their hand? I haven't seen. Let me see if I missed someone that's raising their hand. Nope. All these different boxes to monitor here. Okay. Um, let's see. Well, I think um, unless anything else you want to add, Dr. Kim, about GLP-1s?
I don't think so. I mean, I think there's a lot more to be learned, particularly for adolescents, and particularly what are we going to see in the way of eating disorder, emerging eating disorder pathology when we do have longer term follow-up studies.
Great. Okay. Well, I just want to thank everyone for being part of today's conversation. I'm going to go ahead and share a slide. So if you'd like to learn more about SunCloud Health or refer a patient, please don't hesitate to reach out. My contact information here is on the screen. You may contact me directly or go to our website, suncloudhealth.com. And if you do have any further questions, think of something later, please go ahead and email me at dro@SunCloud Health, and I will coordinate with Dr. Kim in getting those answered. And I know, Dr. Kim, we were asked if you're willing to share your slides from today.
Yeah, I can send them to you in a PDF.
Okay, perfect. Excellent. Wonderful. So, well, again, thank you everyone for spending your lunch hour with us. We really appreciate it. And we look forward to continuing the conversation and working together to support and heal your patients in recovery. So, thank you again and have a wonderful rest of your week. So, thank you.
Hey, everyone, eat abundantly.